Welcome everyone to this afternoon's session, our COVID series, Looking Back and Moving Forward. We are so pleased to have everybody, and I really want to make a special mention and thanks and gratitude to everyone for the time change that we threw at you today. We thought it was incredibly important, especially given the theme today of looking back and moving forward, that we started this whole series back in July with a number of speakers talked about airborne transmission. And one of those is speaking again today at the University of Calgary O'Brien Public Health Institute at 2 o'clock our time. So we thought it was very apropos to promote that and have this COVID series be a full circle event, along with Dr. David Visman, who is also with U of T, as two of our esteemed speakers are today. I also did want to draw your attention to the fact that we are having another session in the COVID series on April the 23rd. And I don't know, Vani, if you wanted to scroll down with that, if you're able to follow along, but we wanted to let you know about that session, which really marks losses and finding lessons. And we are hoping you might be able to use the recordings for your day of mourning events. So the Mario Pasami is speaking around, preventable failures. And we have Natalie Mera from the Ontario Health Coalition talking about the drive to mark losses and find lessons. And I believe we have additional speakers, and someone from the education sector, Tracy Edwards, I believe, speaking as well at that April 23rd session. So stay tuned for that. We also have a Spring Into Action event coming in April, and I wanted to mention our May Day series coming in May. So take a look at our website when you can, and please join us for all of those sessions. The Spring Into Action is April 16th, and it focuses on the secondary hazards of COVID-19, including cleaning and long haulers and discussions from the field. And John's with us as well with Troy Winters around the pandemic survey and workplace mental health around COVID. I hand it over to you, and John. Alec is going to moderate our session today. And so Alec is a lawyer with a long career in workers' compensation and occupational health and safety, particularly around occupational and infectious disease and employment of persons with disabilities. He's currently coordinator of Asbestos Free Canada, chair for Engagement Center for Research on Work Disability Policy. And previously, Alec was the director of the Office of the Worker Advisor and managing director of the Occupational Health Clinics here for Ontario workers. From 2005 to 2008, Alec was the director of the Ontario Ministry of Labour Occupational Health and Safety branch, and you'll see how timely that is for his participation moderating this session. So in that position, Alec was the MOL operational lead for the implementation of the Campbell Commission recommendations and for partnerships with the Ministry of Health and the health sector partners. This involvement had him deeply into pandemic preparedness planning, and also very timely for today's session. Alec played an important role establishing MOL's healthcare unit and Section 21 committees. So he's a graduate of Princeton University and a law degree from the University of Toronto Faculty of Law. So welcome, Alec, and I'm glad you can give us some background before John takes over.
Great. Thanks very much, Kimberly. First of all, thank you, OCAL, for this wonderful year-long contribution you've made to knowledge mobilization, problem solving, and community building. It's been invaluable, both to those in the system and more at the front line. And a special thank you to you, Kimberly, to Val, Tony, and all the others at OCAL and the whole interdisciplinary team who have brought these sessions alive. We're always juggling a lot. I just came off another session on COVID-19. So just as an introduction to our three outstanding presentations today, I'll make a few comments. I think a lot of us on this webinar, like so many others, we've been dominated by day-to-day challenges. But probably like many others of you, in the midst of all this, I've been thinking, how do we lay the foundation for doing better next time? Some of the learnings, I think for all of us, have been heart-wrenching. we need to acknowledge in many ways we weren't as prepared as we could have been. In my own case, I was part of implementing some changes recommended by Archie Campbell, and some of them seemingly were lost to history, and we weren't able to benefit from them anymore when we faced COVID-19. There have been areas where Canada's done reasonably well, but we've done poorly in some other areas, and we've lived through a rough time where I believe lives have been lost and unnecessarily, and our economy has suffered more than it could have been when you compare us with some other countries. Overall, I don't believe the importance of the workplace and Occ health and safety has been properly recognized, especially for our essential frontline workers. They've been praised, they've gotten a little bit of extra money, but here we are a year into it, and we're finally figuring out maybe they should have been vaccinated before some other people. Maybe we should be focusing on the workplace. There's so much potential spread there. But we really can't sort of look at negatives too much. I think there are a lot of positives, and there's a lot of learnings for the future. And if we look to the future, we really need to frame that in terms of things we can do. How can we be better prepared? What foundational changes do we need to make? How do we identify the whole range of areas we need to work on? They range from policy, such as the precautionary principle, to institutional structures. How can we better hear the labor and employer voice, for example, not just the public health voice? Engineering solutions like ventilation, issues around PPE, stockpiling, supply chain, overall planning and standards guidance, tools and resources, interdisciplinary collaboration, and regulatory enforcement. And I'm probably not even listing everything that needs to go into this. It's daunting. It needs resources and support. So today is a really good start, and our presenters today will cover a lot of important territory. And I'm hoping that as you're listening and seeing what they've come up with, be thinking, how can what they're saying contribute to the foundations we need to lay over the next period of months and into the next year to never be as unprepared next time as we were this time. So first we'll have John Udyk. John's got this tremendous benefit of a lot of experience in the past with SARS and the aftermath, and can sort of give us that lens and then bring us forward to the COVID-19 response, some of the things we probably should have learned and that didn't stick, and some of the things maybe that we did learn that we were able to benefit from. Then we've got Rebecca, who's going to do a really important piece in terms of sort of the nitty-gritty of the supply chain, the products. And we really have learned in Canada, we need to be more self-sufficient. Our ecosystem has to be more sustainable, and I think you'll benefit a lot from that. And we'll finish off with Victoria, who's going to present on a lot of work that she's led through the Canadian Standards Association, in particular, on the workplace level, how to work during a pandemic, how to reopen after a pandemic. This is the nitty-gritty that a lot of folks on this webinar will be thinking about right now, and perhaps finding the challenge pretty daunting. So as they're all presenting, think to the future. What positive measures would make the biggest impact? And I'd really urge everybody, try to think about how you personally can make the biggest difference. These OCAL webinars have had a tremendous strength because they brought literally world-level experts from an interdisciplinary perspective into the reality of the front line. And so nothing important is going to change unless the system changes, that's true, but also nothing important is going to change unless the workplace does better. And that frontline intersection of science, tools and resources, structured thinking and planning has to ultimately come home to workers in a workplace, their management in the workplace, their unions, the role of collaboration, how we can talk to each other, how we can listen to each other, and how we can help and ultimately save the lives of each other. So without further ado, I'll turn to the first presenter. And it's always a tremendous pleasure for me to introduce John Udyk, and to do pretty well anything with John Udyk. Getting to know John was a tremendous highlight for me of my career. I did know him before I became managing director of OCAL, but I got to know John very deeply in that context. He's been a tremendous contributor along with the whole team at OCAL to the well-being of Ontario's workplaces, working with employers and labor on a whole lot of fronts. John has been at OCAL since 1989. That's quite a history. And for a lot of people, John is OCAL in a certain way. He's been around for so long. He's an occupational hygienist. He's worked in the Hamilton Clinic, which was really the original OCAL clinic. John's educational background is a Bachelor of Applied Science in Chemical Engineering from Waterloo, a Master's of Science from McMaster in Health Research Methods program. John's an assistant professor at McMaster in that Department of Health Research Methods in the Michael DeGroote School of Medicine. John's certified with the Canadian Registration Board for Occupational Hygienists and the American Board of Industrial Hygiene, so he has significant credentials behind his name. And for purposes of this session, he's been active in following infectious disease exposure and prevention developments in healthcare and other settings, really since SARS, the original early 2000s experience, advising workplaces and unions. This has included something that's really important that I've learned a lot from John about, which is site exposure investigations and surveys. That is where you find out what's really going on. And he's been a part of research teams investigating the conditions of infection transmission. So what John's going to be addressing, as I mentioned briefly before, is sort of SARS and COVID-19. Compare and contrast the response. What are the issues that arose? How can we be more prepared? So you're going to get a foundational type introduction to the history, the living history really, that lasts to this day of our experience with SARS, which was so wrenching for Ontario, where we were a world focus point for SARS. So John, take it away, and I'm really interested in seeing what you've come up with.
Hey, thank you, Alec. And so here we go. SARS 1 to SARS 2, what have we learned? I want to go back a little further just to remind people about the Spanish flu in Canada. It killed approximately 55,000 people, and a lot of them were young adults between the age of 20 and 24. But in the fall of 1918, they had a mutation of the virus, and that's when it produced an extremely contagious and virulent form of the disease. And 90% of the deaths occurred during the second wave of the pandemic. So there's a lot of things that we can identify with. Also, healthcare professionals were probably the hardest hit. Some of these themes will come back. So SARS-1 happened in 2003. It began November the year before in China. The first case, though, was noticed in Vietnam in 2003. And later in Canada in March, it showed up. And in April of 2003, there was a case that happened in an outbreak that happened in an apartment, and it was all the vertically aligned apartments where infected people got, and then they realized that it was the ventilation. In Canada, about 500 people or so, probable and possible cases were identified, and about 10% of those I think 44 deaths in Canada. So in July of 2003, they declared the pandemic contained. So this is from an article about the Amory Gardens, and it shows that when the wind came from a certain direction, it drew the exhaust from the washrooms from one apartment into another, and that's how a number of people who were in apartments vertically aligned got infected. We saw the same thing with SARS-2. This is from an article about August of 2020, and it showed a similar thing where when you had a temperature inversion, the air went down, the gravity exhaust, and it went from one floor to the next floor, infecting people. This also happened in March of 2020 in Hong Kong in a similar situation, except here it went in through the kitchen intakes. Some of the things that were published after SARS-1 from the Toronto experience, a couple of articles here, one suggesting that the study indicated the possibility of airborne droplet transmission. And also there was a study where they compared the use of N95s and surgical masks, and Mark Loeb, who later did a RCT that proved the opposite, at this point said our data suggests that N95 offers more protection than a surgical mask. Now, after SARS, we had the Campbell Commission, where Archie Campbell looked at the issue of scientific uncertainty in a pandemic situation or an outbreak situation. And he recognized the conflict in the way that health and safety operates and the way that infection control operate. And he recommended that the precautionary principle should prevail. And this is the modus operandi of health and safety. And while originally the Campbell Commission recommendations were implemented, the changes were gradually eroded, as Alec was describing, and health and safety, in a sense, was put back into the back seat. And I think that's where we are now. Then we had H1N1, a novel form of H1N1 in 2009. And the original case was a 5-year-old in Mexico who was living close to swine farms and got infected. And it came to Canada in the late April of 2009. And if you look here on the right there, you can see Canada was one of the hardest hit countries outside of Asia when this happened. And we had over 50,000 cases over the years. It's still around. We had a resurgence in 2013, 2014. And the deaths in the second wave was 1.2% of the cases that were recognized. There were a lot of cases, though, that weren't recognized because we didn't have the PCR testing as widely available as we do now. Some of the things we learned, well, this was the first chance to apply what we learned from SARS-1. And for the first wave, we did pretty good. N95s were required for healthcare workers and with suspected patient contact, and PAPRs were recommended for aerosol-generating medical procedures. During the second wave, and once the vaccine came out, however, these recommendations were laid aside, and H1N1 blended into the seasonal flu, where it still is today. So the response to the first wave was generally considered a success, but the second wave, we generally ignore what happened there. Then came MERS in 2012, 2013, and this was started in Saudi Arabia. And here we have a virus being, a coronavirus being transferred from camels to those people who looked after them. And from those people, there was some household transmission and also healthcare transmission when they went to the hospital. And at this time, they said in human-to-human transmission is possible, but only a few such transmissions have been found among family members living in the same household. However, in healthcare settings, human-to-human transmission appears to be more frequent. And it's a theme that healthcare workers seem to be the canaries in the cage, in the coal mine for a lot of these pandemics. There's no vaccine available. I think probably there's not enough people with it. And surgical masks were recommended as healthcare worker protection, which was a change because for pandemic flu, of a novel pandemic flu, it's still, at this time, it was N95s. This is an article I recently came across, which actually shows that it's much more prevalent than the numbers actually show, and that 25% of camel traders who were tested in Egypt were positive for antibodies to the MERS virus. South Korea also had a big outbreak of MERS, and it was caused by a person who came from the Middle East from a business trip, and they had 186 confirmed cases, 38 deaths, and they suspect there were actually over 16,000 cases that actually happened, and it was entirely nosocomial, and except for the first 2 cases. So it got transmitted throughout South Korea through the hospitals and the healthcare system. So then there became a debate. Is it respiratory? Do we need surgical masks or N95s? And when they analyzed the air and the surfaces in South Korea for MERS, they found that there was extensive viable MERS coronavirus contamination in the air and the surrounding materials in the MERS outbreak units. And thus our findings call for the epidemiological investigation of possible scenarios for contact and airborne transmission, and raise concern about the adequacy of the current infection control procedures relating to the surgical mask versus the N95. And if you compare the experience of South Korea here in the bottom corner with healthcare workers with those from Italy, you can see that the percentage of healthcare workers making up the total population of infected patients in the 2 countries, that for Italy, it rose up to over 25% and then came down. But for South Korea, which were using N95s, with a spike in early March or late March, afterwards it stays below 5%. Then we have Ebola in 2013, and we never got any cases in Canada. There were a couple cases in the US, and I think 2 or 4 of them were actually locally transmitted. Most of the others were people who came from Africa and brought it back with them. And it's still ongoing. There is now a virus or a vaccine available since 2019, but we are still having outbreaks of Ebola. So in the period of 2015 and 2020, there was a fair amount of research done on airborne transmission, and this is not a systematic review of it, just a few highlights. And I tried to pick things that were related to Canada. So this is from Sunnybrook in Toronto, and they did some measurements, and they showed that patients with respiratory infection emit virus into the air, which disperses to greater than 1 meter. At that time, 1 meter was the critical distance, and may reach the breathing zone of workers, healthcare workers. Now, in 2016, we met Nancy Johnson from Ontario Nurses Association, and myself met with David Williams and Peter Donnelly from the Ministry of Health and the PHO, along with some others, and we talked about having a workshop. It was an idea that Nancy had was, since we're always fighting during these outbreaks, why don't we get together during peacetime and try to sort out the issues? And so based on that meeting, it was decided to have a 1-day workshop of ended up more than 20 to 30 people, but from the 2 disciplines, from infection control and occupational health and safety, but also anyone in engineering or other relevant domains that achieve these goals. And so it was set, and on May 30th, 2017, after many meetings and a lot of work, we put on this innovation forum. And the goals were to bring together occupational health and safety and infection control, plus other experts, and to try to identify problems and find solutions. However, we had a lot of ideas and proposals, but the bureaucrats were transferred to other departments, and when that happened, everything fell through the cracks, and nothing happened after that forum. And we had experts from all over North America. And there was also a paper put out, again, by local people that talked about bioaerosols and transmission, a diverse and growing community of practice. And they stressed the multidisciplinary approach of here you have infection control and occupational health, but also engineering, biophysics, aerobiology, and microbiology. And we have a paper that measured influenza virus in the air of acute care settings. And here again, they found influenza virus RNA in small particles, medium particles, and the larger particles. And it was also found beyond 1 meter from the person, the source, and it was found in the breathing zone of a healthcare worker. And also in the paper, it talks about that where there is doubt, both droplet and airborne precautions are generally employed, and that droplet nuclei, which are the small aerosols, are responsible for short or long-term greater than 2 meter airborne transmission, and these respirable particles are small enough to be inhaled into the alveoli. Then we had some work from Hong Kong, and what they showed is they took measurements in the outdoor air from October to June of October 2016 to June of 2018, and they sampled every week. And what they found is they could detect virus in the air, influenza virus, and it was always prior to the influenza activity in the community. So it was kind of like a surveillance tool which allowed for the monitoring of early warning of influenza activity in the community. They also did some tests on how far the droplets would go, and they found that when you're talking, the droplets, the larger particles, would only go about 0.2 meters, and even while coughing, they would travel no more than 0.5 meters. So if people are getting infected beyond that, it's not the droplets, it'd be the aerosols. So in Ontario, in January and February of 2020, the standard protocol for dealing with unknown respiratory virus was to use an N95, and any healthcare worker encountering a patient suspected or known to have COVID was to wear an N95. This was a holdover from the H1N1 pandemic, and so this is where we were at the beginning of the pandemic. However, in the first and second week of March, things started to change. There was an article in the Globe and Mail that basically said Ontario is the only one recommending these precautions. And BC uses droplet precautions, but no healthcare workers have been infected there. This was not true at the time, because actually the end of February was the first healthcare worker in BC that was infected. So on March 9th, the Public Health Ontario downgraded the protection for healthcare workers and removed the requirement to use airborne precautions. And so we looked at the documents that the Public Health Ontario put out about the routes of transmission. And when we looked at some of the references, we actually found that these references contradicted what they were being used for. So, for instance, this one suggests that the evidence supports airborne precautions for COVID. And here's another one that suggests that the virus can be shed into the air, and that should be taken into account. And when we looked at the arguments against airborne transmission, we found that they were either very weak scientifically, or the evidence actually cited stated the opposite, or it was a part of a logic that, for instance, the absence of evidence is not the evidence of absence, a logical fallacy. When we look for the evidence for droplet transmission, it was even thinner. And if you're wondering where the 3-foot rule ever came from, well, here's the some of the data that came from 1920, because this was during the First World War. They looked at the distance between the soldiers' beds, and when it was 9 inches apart, the transmission rate was 30%, and then so when they were 3 feet apart, it was less than 2%, and so that's where the 3-foot rule came from. So there was a real failure of the scientific reviews. They were misrepresenting or ignoring the successes in other countries. There's a selection bias or a misinterpretation of the data, falling prey to logical fallacies, citing papers as evidence for positions which the papers actually contradict, not recognizing IPAC failures when they occurred, and requiring the highest level of evidence before acting, only applied to positions opposed by the status quo, whereas the status quo positions required little, if any, evidence. They were taken for granted. And this reminds me of a book that I read a long time ago, The Structure of Scientific Revolutions, which talks about paradigm shifts. And I think the infection control community is in the middle of a huge paradigm shift at this time. And here is a quote from Dr. Anthony Fauci. We were told back in February that the jury is in. It is definitely not airborne. However, as Dr. Fauci here stated, you just have to be humble enough to realize that we don't know it all from the get-go. And just yesterday, he actually thanked U.S. healthcare workers for their sacrifices and admitted that the PPE shortages drove up the death toll. And even one of the biggest proponents of the droplet, Dr. Klumpus, in this online session, you can hear him say the following, and you can hear him kind of stumbling over the words. He said, we need to embrace the sort of the precautionary principle, something that he was against at the beginning. Oh, sorry. I didn't know that the audio was attached to it. I don't know if you heard it, but I did. Basically, the healthcare workers have been the canaries in the coal mine. Even at the beginning of the pandemic, it was only when healthcare workers were getting infected in the hospitals that they finally admitted that it was human-to-human transmission. And if you remember SARS-1 and MERS, it's always the healthcare workers in these situations that were the canaries. The Chinese response, after denying that there was any evidence to support human-to-human transmission, they finally recognized it on January 20th, and they classified the disease in the same categories as SARS and MERS. However, they prescribed a higher level of protection, a Class A infectious disease protective measures, which are usually applied to cholera and plague. And they built 2 hospitals. You remember seeing these the films as these hospitals went up in just 2 weeks' time. The demand for healthcare workers was so great in Wuhan that they had to recruit 42,600 additional healthcare workers from throughout China to help out. And between May 15th and June 1st, over 90% of Wuhan residents were tested, PCR tested, 9 million swab tests. And more recently, a seroprevalence study was done in Wuhan, which suggests that the infection rate was somewhere between 9 and 10%. So if you have a population of 11, 12 million, that's at least about 1 million people infected. The protective equipment that the Chinese used was double or triple layers. They would wear an N95 with a surgical mask on top, and then most other gloves were double or triple. And if you look at the incidence of Chinese healthcare worker infections, you can see the red arrow is when they finally recognized that it was human-to-human transmission. And then by February 11th, they were able to wrestle the rate of healthcare worker infections down to 0. And if you look at these numbers in context of the whole pandemic, this was very early, and also early in the Chinese pandemic. And the 42,000 healthcare workers, none of them were infected using those precautions. And in July, comparing Canada to China, you can see that we were already 6 times. And right now we're at 80,000 healthcare workers being infected. And here's a nice infographic that shows back in January it was 65,000, but now it's 80,000. And it reminds me of the blind people and the elephant. People are arguing about how it's transmitted, and they all have a different idea, and everybody's a little bit right, but everybody's probably wrong. Even the WHO put out a tweet or maybe, I think it was a tweet, a fact checked on COVID is not airborne, and they even suggested that this was fake news. Yet in October, they reversed themselves and said, yes, it can be transmitted through the air. And what was definitive was this workshop back in August 26th and 27th in 2020, where for 2 or 3 days, I think they had sessions that looked at all the evidence and really brought the case home. And if you look at what happens, you can really see it. The green is the droplets, and the red is the aerosols, and you can see they come out together. You can't ignore one without the other. And here's another picture of the different. I really like the spaghetti one. It's enough to give you nightmares. But yet in January 29th of 2021, the WHO is still saying there is currently no evidence that COVID-19 is transmitted through the airborne route. And actually, this comes from one of the WHO presentations in February, a myth-busting presentation. And one of the myth is we need to wear N95s. And they give the reasons why that's not the case, because it's transmitted primarily through droplets, that close unprotected contact. And if, in fact, wearing an N95 may increase your risks, which is absolutely amazing and contrary to everything else you hear in other. And then what about the new variants? You have increased transmissibility. Some of the investigations show that close contact or infections are happening outside of the close contact zone. And people in the EU are being asked to wear N95s in crowded venues in retail and mass transit. Meanwhile, in Ontario, if you haven't been fit tested, visitors to healthcare facilities and long-term care facilities are being asked to remove their N95s and don a surgical mask. And really, those who cannot remember the past are condemned to repeat it. And that's a statement from a philosopher from way back. But if you rather, it's deja vu all over again from Yogi Berra. Thank you.
Thanks very much, John. What a great start for this conversation. We're going to be holding the questions as mentioned till the end, and you've done really well in keeping within time. And if we keep doing that, we're going to have lots of chance to discuss things. So I'm very pleased to move to our next presenter, and someone I don't know and I'm really interested in getting to know through this, Professor Rebecca Hancock Howard, from the Institute for Health Policy Management and Evaluation at U of T. Rebecca's going to speak to something that she has a deep and very broad knowledge and involvement with. And specifically, it's our pandemic response products, focusing on a self-sufficient and sustainable ecosystem. So it's looking at the quality of infrastructure, supply chain preparedness, which has been just in the news constantly through this whole year by Canadian manufacturing policies. So in terms of background, I think Rebecca models a lot of what we've seen in these webinars. She's got a whole range of background and experience. She has a PhD from U of T, along with her Master's of Science from there, and a Bachelor of Science in Health from Queen's University. But she's got involvement in health economics, health technology assessment, health policy, program evaluation, maternal and child health, and economic evaluation methods and outcomes research. So she's modeling the kind of broad thinking and strategic capability that we're really looking for when we're looking at something so complex and interrelated as dealing with the pandemic, both getting ready for it and then responding to it. And I'm interested in also highlighting in her CV that she's worked with the Government of Ontario as senior health economist at the MOH LTC. She also has private sector experience. She did some graduate work at Hospital for Sick Kids, which involved evaluations focused on pediatrics. And in a general kind of way, she's bringing together a whole lot of evaluative approaches and lenses that I think are going to be highly beneficial. So let's hear, Rebecca, what you've got to say, and we're really looking forward to it. Thank you.
Well, thank you so much for the kind introduction. That was really lovely, and thank you for the invitation. I'm really happy to be here today speaking with all of you. And what I will do in my talk is I will talk about the overall products ecosystem. We're going to start with a case study looking at the N95 mask, particularly, and I put it in quotations for a reason that you'll see shortly. And as was mentioned, I am a health economist, and I have a broad range of interests, and I do a lot of different stuff. And this research work that I'll be presenting to you today was a really great experience for me as well, getting to collaborate with some new folks. So this research was supported by the CSA group, the National Research Council of Canada, Industrial Research Assistance Program, and NGEN. And so we were delving into the world of manufacturing, engineering, and innovation. And I fully echo the sentiment that these sort of wicked complex challenges require a lot of different lenses, a lot of different areas of expertise coming together. And so I'll do my best. Some of these things are very complicated, and we'll be looking at some of them at a very high level. So without further ado, I'll get into the talk. So as I mentioned, I'd like to tell a little story about N95s as a case study, and which is more specifically than a mask face filtering respirator. And looking back over the seminars that have happened already through this series, I believe there's probably a good amount of expertise in this. And a lot of this will also pick up on threads of what John was just talking about in terms of airborne transmission, who needs to wear what, a lot of confusion on that. And we'll look at some lessons learned from what's happened with N95s in particular, which really does offer a lot of lessons more broadly for looking at the products that we need to respond to a pandemic and how to make a more self-sufficient ecosystem for products needed to respond to a pandemic here in Canada. And so again, getting into the research that we've done in partnership through not only my Institute of Health Policy Management and Evaluation and the Dal Atlanta School of Public Health, but also with our Faculty of Applied Science and Engineering here at U of T, the research partners that I've mentioned, looking really broadly at what is our ecosystem and what could we do to fill the gaps that currently exist in our ecosystem, and what has been done already. And again, things have been moving so quickly. This year has just been overwhelming, I'm sure, but it's pretty interesting to think about how things looked even last fall compared to now. Things have moved quite quickly on some fronts, and in some fronts we can still do a lot better. So I'll start to tell my story about the N95. So what is an N95? So an N95 is a specific type of face filtering respirator built, tested, and certified to NIOSH standards, with NIOSH being the National Institute for Occupational Safety and Health, which is a US federal agency. It is not only used in healthcare settings, but this mask is also used in settings like mining, construction, and painting to filter out particles. And so I wanted to highlight the fact that this is certified by NIOSH. It's, for me, I sort of got into thinking about this as the difference between a Kleenex and a tissue. It's sort of like the brand. So N95 means NIOSH. And when we talk about standards, I think it's useful to just quickly define what we mean by that. So the Standards Council of Canada defines a standard as a document that provides a set of agreed upon rules, guidelines, or characteristics for activities or their results. Standards establish accepted practices, technical requirements, and terminologies for diverse fields. And so the standards that NIOSH provides about N95s are very important for this product. I won't spend too long on this slide because we've gone a little bit over this, I think, but that N95s are often called a mask, but they are in fact more specifically a respirator. They require fit testing. They are different from a surgical mask or a medical mask. They have some features in common with the elastomeric face piece respirator, which is again also used in industries that like construction and painting. It's important to understand that the N95 is the mask that's required when you're trying to prevent against aerosol transmission. And so thinking back a year ago when the pandemic started, the need and demand for N95s skyrocketed. And I have on the right there a news clip from early April when we only had about a week of supplies left. And I also have a clip from a paper that tried to estimate our PPE requirements for Ontario in acute care settings for N95s. And again, you can see we're still using the term N95, which again is specifically to the NIOSH certification, but it's become sort of the catch-all term that we'll use for that. And trying to understand, how many masks do we need was a really difficult task early on, and we didn't have a lot. Why did we not have N95s? So we have stockpiles. There are some local stockpiles, but importantly, we have the National Emergency Strategic Stockpile as well, which is the federal stockpile. And in cases of both our local and federal stockpiles, the stockpiles have not been managed in a way such that the stock was turned over or used. So a lot of the masks that were in the stockpile were expired. And so this sort of emergency backup plan that we had hoped to rely on, I think, didn't really work. And here I show, I know John went over some of this as well, the recommendations on who needs to wear what mask. And again, specifically looking at the N95. They are still, as recently as December 2020, we're saying you really only need to wear this mask if you're working with COVID positive patients when you're performing these aerosol generating procedures. And otherwise, you can wear a medical mask. And here it's important to note that the WHO mentions FFP2 and FFP3 as a sort of equivalence to N95. And so I think this is important for those of us who are starting to become familiar with the world of standards and terminology for these types of products. It's important to know that this is the European standard, so it's in many ways largely equivalent to an N95, but built to the European standard and not to the NIOSH, not certified by NIOSH. And again, here's statements from the US CDC not too long ago. And it's really discouraging people from using N95s with sort of this idea that these are really critical supplies. They need to be conserved for healthcare workers and medical first responders. So this is really something that people have been discouraged from using in other settings because they're in such short supply, and they should be prioritized for people working in healthcare. But even for people working in healthcare, there wasn't enough supply of PPE. So with, again, a lot of the guidance being that these products were really supposed to be conserved in the face of massive shortages for people who were working with COVID patients doing particular types of procedures. People were reusing masks inappropriately in some cases. We've heard a lot of stories of people coming up with ways to try to sanitize or disinfect masks. And here is a sad case of a physician who contracted COVID at the job and passed away. And her family said she'd been reusing her same mask for weeks, if not months, which is a very tragic story. And other things that were going on through all of this was that we realized we needed lots of masks. Our stockpiles were not going to fill that need. And everyone in the world was trying to source masks. And we were trying to bring them in from all over the place. And we actually had no domestic production capacity for N95s back when this started. So we didn't make them here at all. And the traditional trade relationships that we might rely on, or norms, were really threatened. So it was probably in some ways hard to escape some of these headlines about crazy things happening with masks disappearing, flights, cargo disappearing. Everybody was scrambling, everybody was desperate, and all kinds of crazy stuff was happening. And so I think that was sort of front headline news, but I think there was one critical bottleneck that maybe you wouldn't have been aware of if you weren't more deep into this industry, which is that it was not only the trade relationships that were threatened in terms of importing masks at this time, but NIOSH itself suspended new applications for N95 certification by manufacturers outside the US. So I mentioned that we didn't have factories making N95s here at the beginning of the pandemic. And if they wanted to start making masks, they wouldn't be able to be certified by NIOSH as making N95 masks to their standard. And so there is guidance for Canadian manufacturers to make masks that are roughly N95 equivalent, but they would not be called an N95. They're called a PFE. I'll get a little bit more into that in a sec. This was another huge challenge that we had early. So as I mentioned, we didn't have factories making N95s. There's a critical key component in the N95s, which is the melt blow, which is the polypropylene in the mask, which is this blowing aspect gives a random dispersion of the material, which provides better protection from the viruses going through compared to, say, a woven fabric where it's more uniform. And so we didn't have this machine to be able to make this key input that you need for the mask production. And we needed to import just the things to make the melt blown, which you need to make the mask. And those needed to come from Asia or Germany and be made to Canadian specifications. And so this, if you were going to be doing a critical analysis of the supply chain, this would have been a key feature, the fact that we didn't even have melt blown in the country either. And so I'll describe in a bit more detail the research that we did, but I will just summarize some of the things that we heard from stakeholders about N95s. And so we did have a lot of local folks begin to make masks, and they were able to rely on the NIOSH standards, but we sometimes in some cases didn't have, right at the start, some of the tacit knowledge and skills to do the testing. We also didn't know which labs had the capacity to run which tests. There was sort of an all hands on deck feel, I think, where some tests were being done or people wanted to help but maybe didn't have accreditation to do the testing, or they were accredited by foreign bodies. And we also heard that this issue about the N95 specifically is difficult because a lot of healthcare workers do have a brand preference for that one. They feel confident in the N95 over, perhaps I mentioned already, another equivalent would be the FFP from Europe. Canada developed guidance to make a PFE. 95. And so with these other products, people still don't feel perhaps as comfortable as they do with the brand they've come to know. And that this also is reflected in a lot of the request for proposals with the procurement that's done. Instead of saying N95 or equivalent, a lot of them still say N95. And this really sort of, again, chokes off opportunities to be more diverse in our procurement practices, which can improve resiliency. So just calling out a few things about the face filtering respirator, and this is my goal to get away from being really explicit about N95 and maybe getting more to this idea of being N95 or equivalent, or just saying FFR. As an ecosystem case study, so what we really saw with this product was that the stockpile didn't really work. We didn't have enough stockpiled and the stockpiles were expired. And on top of that, sort of the needs and distribution was poorly understood. So even when we were just thinking about using this in healthcare settings with healthcare providers working only with known COVID positive patients, we still didn't know who needed masks, where to go. We heard that people didn't know how to get access sometimes to the stockpiles. And so the sort of needs and distribution of where the products were that we did have and how many people were going to need down the line was something we didn't have a good sense of. As I already mentioned, we didn't make these masks here in Canada in the start of the pandemic, so we were entirely reliant on imports. We were entirely reliant on certification by NIOSH for the N95 type mask, and this led to sort of a critical bottleneck. And the supply chain was strained for this really key input material of meltblown. And we sort of saw this in the guidance and heard this again from John, is that there's a hesitancy to sort of expand the use of N95s outside of these sort of specific narrow ranges. And it's something that's led to people inappropriately reusing masks or rationing masks. And so we've seen, this critical shortages has really limited availability of PPE. And so we see a clear need to improve the sustainability and self-sufficiency of products used to combat future pandemics in Canada. And so here I'll talk a bit more about the research that we've done to try to understand what is the current state of the pandemic response products ecosystem in Canada, and what do we need to do to create a self-sufficient and sustainable pandemic response products ecosystem in Canada. And I'll define a little bit more what each of those terms mean or how I'm planning to use them. So obviously an ecosystem is a complex network with lots of interconnected things going on and dynamic interactions. And, working in the academic world, I know there's people that could be deep experts in the tadpoles. We're kind of trying to look at how the tadpoles relate to the frogs and the flies and how it all works together. So just as a bit of a definition and a disclaimer about, kind of trying to take a high level look at how a lot of these things work together. And so the research that we did, as I mentioned, in partnership with CSA and GEN and NRC, was to develop a project framework where we worked a little harder to define what we mean by this ecosystem, what we mean by these needed products. We conducted stakeholder interviews to validate our framework and our scope and inform our development of an understanding of gaps in the ecosystem. And we spoke to 27 individuals during that phase, and this was mostly in the fall. And we conducted an environmental scan to identify papers and reports relevant to our questions. We synthesized all of this into an understanding of what the gaps were, and we used that to develop some recommendations. We developed case studies to illustrate key challenges in the current ecosystem, and I sort of presented one of those now on the N95. And we took the recommendations to stakeholder roundtables, and we discussed, we had 6 roundtables with 19 people to discuss the recommendations. And so here I have a slide just to show what I mean when I talk about products. So I talked a lot about N95, which would come under the PPE. Other products that we think were important to look at to respond to a pandemic would be medical devices. So things like ventilators, testing and diagnostic equipment. So something like this, testing kits or swabs, air and surface sanitization, and public health equipment. So under there would be things like non-medical masks and hand sanitizer and stuff like that. And we purposefully chose to leave out, sorry, was there a question? I thought I just heard something on the line, but I'll just keep going if there was anything. We purposefully chose to leave out pharmaceutical products and vaccines from the scope of our project that we did. And this was because they have sort of unique supply chain and regulatory considerations. But it's been interesting to see, whereas PPE was such an urgent crisis need early in the pandemic, and now we've come to a point now where I think we've been talking a lot about vaccine domestic production capacity, so obviously very important. And there are some certain parallels for sure between being able to be sufficient, not wanting to rely solely on bringing things in from the outside and how important that is. But we're really trying to focus more on the products I've listed here. And when we talked about the ecosystem, we described it under 3 key domains, those being quality infrastructure, supply chain, and sustainability. And under quality infrastructure, we have the components of consensus documents, which would be things like guidance, standards, and regulations, conformity assessment, so that would be the process of certification and testing, and licensing. And under supply chain, we talk about production capacity, so our ability to make things, the procurement processes to buy them, things like logistics, inventory management, and traceability. And under sustainability, we're looking at the sort of economic, labor, and environmental issues and implications of all of these. And so we ended up coming up with 12 recommendations for each under our 3 key domains that I'll describe here. And I also know from, I was listening to John's talk and have thought about this as well, about all the coming up with recommendations that you hope don't sitting on the shelf. So I hope we can make some really meaningful progress on some of these. And again, we already have the production of masks. So I'll go into the 12 recommendations here. So under quality infrastructure, we first say to improve mask design standards and guidance. And this is actually the only recommendation that's really specific to a particular product. And I think it's because the masks were such an important, critical thing that we just heard so much from stakeholders about the masks. Second is to align regulations and standards internationally. And this, thinking about an ecosystem and how things all relate to each other, also relates to our sort of need to support Canadian manufacturers. One of the reasons we don't make a lot of things here is that Canada is a relatively small country and small market. And so being able to share things more easily or to understand their equivalents is really important. So hopefully our many domestic manufacturers who are now making PFE 95s will find a market for those outside of Canada as well. And so the other recommendations under quality infrastructure are to invest in product testing infrastructure and to invest in traceability infrastructure. And this is, to look at embedding better sort of tracking and tracing and barcoding into products at different levels so that we can have a better insight into sort of what the needs are, where things are going, doing recalls if we have to, if there are bad batches and things like that. Under supply chain, our recommendations were to redesign the National Emergency Strategic Stockpile. And I think this is both to look at it from a lens of what needs to go in there. Is it designed to respond to, say, natural emergencies? Or is it meant for pandemic responses? And then would that, shape how you might consider things? And then also to think about how that stockpile gets refreshed. I don't think anybody likes the idea of a bunch of goods and materials sitting in a warehouse going unused and then getting thrown out. Nobody really wants that, I don't think. And next, to facilitate an open procurement marketplace and to look more broadly into procurement practices. To inform demand through enhanced scenario planning and forecasting. I think, again, this ties back into the idea of traceability, of wanting to know where things are, how much we have, how much do we need, and to really get creative in thinking about what challenges we might face down the line. So we've been through a few pandemics in recent memory, and they've all been kind of different. So we know there will be more. So to have some people who are really dedicated to thinking through, what are the needs for different types of scenarios we could be facing, and under those conditions, how much PPE, for example, would we need?
Rebecca,
And
it's just Kimberly giving you a little time check.
For sure. Time left do I have left, Kimberly?
You're pretty close, but I don't know how many slides you have left.
I don't have many slides left, so I can just finish up after this one.
Okay.
So I will and to develop and maintain diagnostic testing capacity. Next is to support economic environmental sustainability. So under this recommendation, we have standardized reprocessing of PPE and medical devices to develop pandemic response products that are recyclable, compostable, or biodegradable, to support Canadian manufacturers, and to support innovation and evidence generation for new technologies. And I'll just go finally to, I did have a few more slides that I was going to do. Flip the thing, again, echoing what John was saying. I think importantly that we saw in Quebec a couple of weeks ago that there was a ruling that any worker in a long-term care unit that was sort of a hotspot should wear an N95. And so while the Ministry of Health in this case might have said that that person would have been fine with a surgical mask, there was actually a ruling from a judge at the Labor Tribunal saying no. So I think that would be interesting for this audience to see that there's some discrepancies between what some of the health guidance is saying about what's needed and then from a labor perspective what's being said. And then seeing, better, more different and better masks being made for those of us just in our regular lives and other workplaces. I think we need a standard for a consumer public mask so that we can have more confidence in masks we're all wearing in our day-to-day lives. That's an important step. And just in terms of what's been done, so interim guidance for domestic production of masks was developed. As I said, we're now making those here. And long term, it would be nice to harmonize it better on the global standards. Health Canada did move very quickly to import more, and that has happened. And as of December 2020, there are 10 Canadian small and medium enterprises authorized under this interim order to make FFRs. There are 2 larger companies and there are 3 melt-blown polypropylene manufacturers. So these have moved quite quickly. And I'm going to end here and say that, while the making of the stuff is important, there's a lot of things that come in terms of quality infrastructure to make sure that we're making things properly. So it's not just the physical making of it in the factory, but all of those wraparound standards and certifications. Some of these are very locally situated requirements, but it also needs sort of a global lens of wanting to look externally and make sure that we can take our products abroad as well. We need better products, particularly when it comes to masks, but more effective masks for the public, masks that are more breathable and recyclable or reusable. And again, bringing together lots of different viewpoints into these challenges. We heard a lot about the need for greater collaboration between medical standards and manufacturing communities. And I'll stop there.
Thank you so much, Rebecca. I'm sure I speak for everyone. You've taken us into a world a lot of us don't know too much about. And we're seeing the complexity and interrelatedness of that world. And I'm sure there'll be a lot of related questions. Now we'll move to Victoria, who's the last presenter. And I think we're staying pretty well on time. So this should mean that we have a good stretch of time for Q&A. I'm really getting to know Victoria really well. We spent part of the morning together. And Victoria is another really good example of somebody who's pivoted during COVID-19. I got to know Victoria primarily around occupational disease research and respected her expertise and her knowledge tremendously. And yet we hit COVID, and here's Victoria suddenly in the sort of research and standards world, looking at a Canadian Standards Association standard for businesses to reopen and operate during the pandemic. And it just shows it's another facet of what Rebecca just showed, which is 10 Canadian firms are making stuff they weren't making a year ago. It's an amazing thing, and it's necessary when you have something this serious. So Victoria's background is she's an assistant professor in the Della Lana School. She's Associate Director of the Occupational Cancer Research Center, and she's a registered occupational hygienist. And her sort of mainstream of her career has been focused on the measurement of workplace exposures and the assessment of exposure in occupational epidemiology. So way beyond infectious disease, but I'm sure a lot of that skills and knowledge has helped a lot. And what Victoria is going to be doing as our last presenter is looking at the areas of research and standards development that she's been encountering over the last year, and with some guidance for the future. And this morning's session, our workshop that we were in together, was really about broadening out that work, making it more sustainable, being more, I guess we'll say, comprehensive in what we're addressing. So I'm really looking forward to what Victoria's got to present to us today. Thank you.
So thank you for the introduction, Alec, and thank you for the invitation to present on some of this work. So as Alec alluded to, over the last year, I have added or pivoted to do more work on COVID-19. And in part, that's because, COVID-19 is an occupational disease. There are workers that are being impacted. And almost a year ago now, we were approached at the University of Toronto around the possibility of doing a rapid research project on workplaces and COVID-19, specifically in terms of providing some guidance on reopening or operating during the COVID-19 pandemic. And so I became the lead of that work, and with a group of graduate students worked on this last summer. We did have a project advisory team or panel here that I'm showing you with representatives from the University of Toronto as well as the CSA group. And I always want to acknowledge the contributions of Michelle Prévost, who made really significant contributions on the water system section of the report. And you'll see where that comes up as I go through the work that we did. But we were supported by the CSA group via the MyTax Accelerate program. For folks that are familiar with that, it's a program meant to sort of facilitate partnerships. So the aim when we set out with this work was to review and summarize the occupational health and safety prevention practices that could support safer reopening and the ongoing operation of workplaces during the pandemic. So really, when we started, it was a rapid review of what was out there. It wasn't done with the intentions of standard setting, even though that was partly where the financial support was coming from. The scope was limited to things that could be done at the workplace level. So we didn't include regulatory changes or policy changes that might be implemented at the local, provincial, or federal levels. And pretty quickly, as we started to review the evidence and the guidance that existed back early in the pandemic, we did exclude the patient-facing healthcare settings and activities of first responders because these were quite different exposure scenarios and also workplaces that had never ceased operating. And so those parameters were placed on what we did. And here's a little snapshot of the methods or the approach we took. So we scanned basically anything we could find that related to COVID-19. And that was both, this was May, it was still very early. There was already, though, some scientific peer-reviewed work coming out. There was a lot of gray literature. There was existing standards that were applicable to the COVID challenges. There was some guidance documents. But we also looked to the media to see where outbreaks were happening and what people were saying, because that was really the most, it was the most late breaking kind of source of information. And we worked to summarize what we found. We worked to identify places where there was consistency in thought, so where everyone was sort of saying the same thing, and areas where there was still quite a bit of difference of opinion or perspective or interpretation of data. And we went out with our draft report through three rounds of expert review, to subject matter experts, to industry experts, and to public health leadership across the country. And given the workload that these folks had, we really had quite a very encouraging and surprising amount of engagement on the draft report, and got a lot of really critical but constructive feedback that was very helpful. And The structure of the report that resulted, there was a part A, which is a long narrative research report that is available on the CSA group website. It's freely available. This is certainly, this is certainly the area where I'm more comfortable, but we did translate the narrative report into a more short and snappy guidance document, which stands as part B of the report. And although this looks and feels a bit like a draft standard, that wasn't the intention. It was really more to pull out the key messages that we thought workplaces could use in the short term. And so here's a high-level summary of the report that we created. And so through the review of the documents and the guidance and things like that, we organized the information into 3 domains. And so the domains that we used for organizing the report were the building system, so the physical structure in which work is happening, the workplace or the workspace, so the where the workers are doing their job, and then the worker themselves and ensuring physical and psychological health of the workers. I'm going to walk through these on the next 3 slides. But we did also identify 2 major cross-cutting themes in almost everything we looked at. And one was communication and the need for open dialogue, ongoing dialogue, meaningful dialogue, especially in the face of uncertainty that was present at the beginning of the pandemic, and how critical this sort of honest, forthcoming communication really was to communicate what needed to be done and the rationale. And then the occupational health and safety culture was the other cross-cutting theme. And this really connected into having a positive culture or good culture within an organization being associated with better health and safety performance generally, and the idea that this was likely to also be very applicable in the case of COVID-19, in that firms or organizations that had better culture were expected to adapt better and to react, quite frankly, because we were all reacting at that point. And of course, I've lost my mouse now, so let's see, there we go. So the first domain that I'll walk you through is the building systems. And so this is really about the physical building. The goal here is partly related to the guidance was about reducing transmission of COVID-19 in the workplace, but it also speaks to reducing other hazards, so chemical and microbiological hazards that may arise when buildings are unoccupied or operating at reduced occupancy. So there is, evidence around the role for ventilation and transmission, and guidance from organizations like ASHRAE around the operation of ventilation systems in a manner that can reduce transmission. There's also guidance from the American Water Works Association around the safe operation of water systems and the preparation for reopening after periods of no occupancy, including things like flushing. And this really speaks and focuses largely on Legionella, but it can also impact things like metals that may leach in over periods of low or no occupancy. And obviously cooling towers for folks around Legionella. This is one of the larger hazards, and the need for continuous operation here. The second domain was around the workplace or the workspace and the design or the layout, the organization of work. And here these guidance or recommendations really spoke to how to best reduce transmission in the workplace, largely through the implementation of public health prevention measures that we're all very familiar with at this point, but promoting and ensuring physical distancing can be maintained in the workplace, and the many different ways that that can be accomplished. The need for improved or more frequent cleaning and disinfection, good hand and respiratory hygiene. And then we did also cover in this particular domain around the use of masks and face coverings or respirators where needed. And so that sort of picks up on some of the earlier talks, and I've seen lots of questions in the chat there as well. And many references here to a wide range of organizations and different levels of government. Certainly this guidance, particularly on the last point here, did change quite rapidly over the first 6 months of the COVID-19 pandemic. So we were definitely doing our best to keep this up to date before it went out for publication in September of 2020. The third domain was around supporting workers, ensuring their physical and psychological health during this pandemic. And this was really had a lot of different things in this domain, both aiming to prevent the introduction of COVID-19 into the workplace through things like screening before coming on site and education around prevention measures, but also preventing transmission within the workplace, the provision of accommodations, important considerations around accommodations being that the pandemic may have in fact changed accommodation needs, and that these changes need to be handled equitably. The need to acknowledge and address the challenge of new work environments, including people working from home or working in isolation or working alone in ways that they hadn't previously. And the need within these new work environments to not just be thinking about COVID-19, but to be thinking about other workplace hazards that may be either introduced or exacerbated by this change in the work environment. And the need to support workers' psychological health, obviously lots of stressors like kindergartners in the background, psychological stressors arising both from work, but also personal aspects of people's lives. And one thing that I'd never really considered in occupational health and safety, but the need, and here we worded it as the awareness of financial supports, ensuring that workers are aware of what's out there. Because one of the primary prevention measures really is to have people who are sick stay home, or have people who have had exposure to stay home, and asking people to make that personal choice that has very real financial impacts for many workers is a really big deal. And we need to try and support that as best we can, whether that is through employer provided sick days or sick day benefit through government programs or initiatives. So the key messages from our report, the first being sort of, I think we all know that are on this call, but COVID-19 is a really big challenge for workplaces. Many workplaces that had never dealt with a health hazard, in a sense, were right at the front lines of this pandemic. They need to prevent the introduction into the workplace as best they can, but also that prevent transmission within the workplace. And our recommendation really was to consider three main spheres of prevention, being the building, the space, and the worker. And what I haven't talked about today, but is in the report, is the importance of using layered controls or multifaceted controls, that we don't really want to be selecting a single thing and putting all our eggs in one basket. We want to be building redundancy into our prevention approach so that if there is a failure somewhere, we have backup. So we want to be implementing many different controls. And remembering, obviously, that particularly in this case, that occupational health has quite an important role in the larger public health situation, because transmission of COVID-19 at work can affect people outside of the workplace. It's not like other exposures in the workplace where it sort of stops at the property line. And I know that's a bit of a simplification, but in this case, the worker can bring the exposure with them, and they can also take it home to their families and their communities. So just I thought I'd touch quickly on, as I said, the report was released in September of 2020. The work really wrapped up in August. And, obviously things are changing very rapidly. So what did we miss? What's changed? Well, I think when we wrote the report, we were pretty comfortable with the fact that COVID or SARS-CoV-2 was in the air, and that inhalation was an important route of exposure, but there was still a lot of discussion around the terminology. I do think that is resolved, or pretty close to resolved. I think there's people who probably better equipped to discuss that than me, but there's big implications for controls once we make that shift. There's been a lot of attention on paid sick days and how we can better support workers staying home. This is obviously imperfect. We know there's asymptomatic transmission, but it's a really big piece in my mind. The local context, I know OCAL's done great work on this. It wasn't very prominent in our report, the idea that different places are affected differently, and how can we manage that and be adaptive and responsive to that. I do think we have some limitations in terms of the available data and the capacity to interpret that. But there are also a few other gaps. We didn't dive into rapid testing in the workplace, which I think is gaining a bigger role in the prevention strategy. We didn't talk about vaccines. Last summer, I'm not sure many people would have thought that we would be vaccinating at the rate we are at this point in time. And certainly we didn't discuss the variants, though I'm sure the infectious disease folks saw this coming. It really wasn't on the prevention radar in the documents that we were looking at and the people we were talking to. So certainly what hasn't changed is we know we need controls. We know we need many different approaches, using the Swiss cheese model. We want many layers in our prevention approach, and we want to ensure that we have as low a chance as possible of having the exposure event occur. I do think we still continue to need better data about work, and this is a bit of a soapbox for me, but we're not collecting systematically information about work for the cases of COVID-19 in Ontario, and we don't have information on work in our administrative data. We have made some really big strides over the course of the pandemic in terms of collecting other social determinants of health data, race and income. And in some areas like Peel, I'm showing you an example here, certain health units have really taken the lead on collecting information about work. And so I think there is good leadership here. And I do hope that this is something we can also learn from, because it does allow us to see where prevention is working and where there might still be gaps. And I think this is really quite helpful. So just to remind you of the structure, the Part A and Part B, and what has happened since the fall is that, as Alec mentioned in the introduction, the CSA group has just wrapped up a workshop agreement that was related to this research report sort of broadly, as well as other existing standards. So there is an ISO standard for safe working practices during the pandemic. And CSA is, again, the standards landscape is very new to me. And this is my first go around the ride, I guess, about standards development. But really the aim of the workshop is to give direction on the need for standards or not related to infectious disease pandemics in workplaces. So there were 2 meetings this week of a group of about 25 leaders, diverse leaders from across the country. And so there will be a workshop report that comes out of this activity, and that will be publicly available, I suspect, in the coming month or 2. And so I will stop there with thanks to the folks who really were critical to the report. And there, as I said, you can find it online and you can put those terms into your search engine of preference. And thank you very much.
Thank you, Victoria. And we are exactly on time. I think OCAL's got a great track record for moving on through, which means we've got a half hour to work with. I've got some closing remarks, which will literally be 2 minutes. So maybe, is it Kimberly going to take over with questions? There's so many, we're going to have trouble getting to all of them, I'm sure.
We're going to have Jennifer read them out, and Alec, you would have volunteered to moderate, how the panel should function in terms of answering the question. So we can throw it out to the whole panel to direct it at one particular speaker. We find it much more rich that way. So go ahead, Jennifer, with number 1. And we will go live to the audience as well.
Thanks, Kimberly. The first question is, were the H1N1 lessons and using N95s or PAPRs just in Ontario or nationally?
That should probably go to John.
Yes.
And the speakers can turn on your videos. If we start to lose bandwidth, we'll have to turn them off, but we'd love to see this panel.
Well, I did answer that in the chat. The CDC in the U.S. Recommended N95s, and if available, PAPRs for aggressive or aerosol generating medical procedures. I'm not sure what the other provinces, there's so many jurisdictions and keeping track in such a long time ago. But I believe at that time, Ontario was more or less a leader. In H1N1, Canada was the first country to sequence the genome of the virus. So we were globally in a very much different position back then than we are now.
Okay. Next
Jennifer.
The next question is, how many companies in Canada have started producing N95s or elastomeric respirators since the pandemic started? And where are they and how do we find them?
That's Rebecca had that in her presentation. Maybe she can expand a little bit.
Yes, so we have 10 SMEs and 2 larger manufacturers. So it's pretty great. But I think the challenge, I'm glad that you want to find them because, as I mentioned, a lot of people still have this focus on the N95s, and the Canadian companies are authorized to make a different brand, brand, maybe not the right term, but different standard PFE 95. And so it's important to maybe put that into the procurement of saying N95 or equivalent, and then that will help you. There's 2 organizations I could highlight as well. There's Canada Strong and Masks for Canada, and they I could announce it just now, but they compile lists, I think, of locally made masks if you're interested in buying local.
Maybe I could add something to this one. OCAL has put quite a lot of effort into looking beyond N95s, and we had a really great session on the elastomeric respirators, I guess just a couple of weeks ago, where we learned a lot about how with a well-supported program, elastomerics can be a big part of the solution. And of course, you're getting out of more or less disposable product and into a much more robust, long-term usable product. And I wonder if Rebecca, you could comment a little bit on that. We wouldn't want people leaving the session thinking that the only solution is manufacturing more N95s in Canada. There's lots more to it. Maybe comment on that.
Absolutely.
Too. I know you've been really careful not to present that.
I fully agree about the use of the elastomeric masks as something that's potentially more reusable, because obviously the garbage we're generating is really concerning. And there is also a call and a focus on biodegradable masks. And so those are another option that are coming forward. And then reprocessing is something that gets a bit tricky for products that are not sort of intended to be single use. It's a bit of an ethical, moral, legal quagmire as to whether you can reprocess and reuse products that are labeled as single use, although that was something that we were doing quite a lot of with masks and stockpiling them for emergencies when things were in quite a crisis mode. So I think that idea too of the reprocessing is important, and then reprocessing is much easier with the elastomeric ones. So I thought that would be my additional comment on that, I suppose.
Okay, looks like Victoria might have a comment. She's put her hand up.
Well, yeah, I put my hand up. Thank you. I guess I also have a question that I might move to John, because I was really surprised that there was such hesitation about the elastomeric respirators, and I think it arose from the like the ability to clean them between uses and things like that. But my understanding is that in some areas, like British Columbia, they are using them in healthcare, and in other areas they're not. And whether you know anything or anyone knows anything about why, like how those decisions are being made, because they seem to be coming to different decisions or different conclusions.
Yes, that's true, Victoria. They've also been used in Ontario. I've been advising a lot of workplaces and unions about it, and my hesitation is you need a good infrastructure to support the use of elastomerics. I've heard of one hospital basically giving the respirators to the healthcare workers and giving them a 20-page booklet on how to clean them and expecting them to do it themselves. And also the maintenance, you have to maintain the valves, and if they get cracked, you need to replace them, you need to disinfect them. And, you know, if you're going to go there, don't just go there on a whim. You need a plan. You need the supports to clean and to store, to repair, to monitor the use, to, do the fit testing and things like that. So sometimes people ran to them as a stopgap. And I used to work in a pesticide factory where I had to wear them continuously 50 hours a week. So yeah, I have firsthand experience. It can be used, but you have to do it right. And so that was my hesitation in recommending them. But there are healthcare workplaces that have implemented the use and have done it right. But I was scared that they weren't going to do it right. And maybe if I can also add about the respirators, people from the Mask for All group actually last weekend did some quantitative fit testing on a variety of respirators. And there are also a new design which goes horizontal or vertically instead of the horizontal. And the fit for those is just quite amazing compared to the horizontal design. But yeah, there's lots we can learn if we just, sit down and do it.
And yes, Rebecca has placed in the chat both the Masks for Canada link and also the Canada Strong Masks link. So thanks for that, Rebecca. Go ahead, Jennifer.
I think someone else has added, I think the list of the authorized medical devices from the Health Canada website for, I think that's the list of the manufacturers.
Oh, thanks, Kevin. Great.
Can I just add one more thing? There's also a link in the chat, which people really should use if you haven't been at the event, to that elastomerics session. And a lot of the issues that John just brought up were addressed in the session. And of course, you learn you've got to have a robust program. You've got to support people. You don't just launch into it overnight and expect it to work. So there's a lot of really good material in that webinar. Next question, maybe.
Thanks. The next question is, the lessons from international alignment in the GHS for data sheets label of chemical products are that they aren't harmonized and tend to go to the lowest possible common features. How could standards and regs around PPE be aligned to the best possible standards?
Okay, on this one, maybe Victoria, could you give it a start? Is it something you've worked on? I actually know something about it as well, but let's see what you folks, and John, do you know much about this?
Yeah, I don't have a lot to add. I mean, my only comment would be, we're not really harmonized even across Canada. Like we're very, in occupational health and safety generally. And I do think that more harmonization would be better. But I do think that we don't want to go to the lowest common denominator. So that's certainly a potential problem. But I can't speak to the PPE harmonization particularly well. Did you want to take over, Alec?
Let me do the GHS part. Some people might know what GHS is, some people might not. The globally harmonized system has to do with, I guess, especially with labeling and related matters regarding hazardous materials. And I was very, very involved with this at Ministry of Labor when I sat on the Cal-OSH committee. And in fact, was part of the harmonization exercise to try to harmonize regulations. And what happens in the international trading environment, which is so competitive, you get these pressures for one country not to get out too far ahead of others. And we were held up for years because the Americans didn't want to adopt some of the elements of GHS. So we were literally ready to go for years. I think it's a general problem that's faced in the regulatory realm that, I'll call it international capitalism or whatever. Business is international. and pressures come on national governments, which may want to do the right thing, but they feel that if they impose standards that are too high, they won't be able to compete. So I think somehow or other, there are battles to be won in the international realm, which are very, very hard to win in the national. Having said that, every once in a while, a country has to step up and move a little bit ahead. And that's what I would advocate for Canada. I'm wondering if that came up, Rebecca, around the standards work you were encountering. In fact, I know it's come up because it was in the media yesterday, and the comment on the launch of the CSA respiratory protection respirator standard. Maybe you could comment on how that's playing out.
Yeah, I mean, I think there's this tension that I talked about a little bit between needing to have like homegrown domestic capacity to do testing, to develop standards, to make masks and to do all that stuff, but to do it in such a way that it's easy to export, because companies are not going to be able to sustain themselves just trying to serve the Canadian market. And so, I mean, I think that's sort of the tension that we have to realize, like, how much do we need to do here, and how much can we sort of work with others? So I think, you know, a lot of the FFRs, the experts could tell you more about the ways in which there are slight differences between some of these standards, but they really can be considered equivalent in terms of how well they might filter out viral particles. So, you know, I think, you know, there was a lot of, I think it would be good to look back at this experience of making the local guidance on the PFE 95s that they've made on how to develop masks here, and see what's worked well there. And again, you know, people moved so quickly on this. It's quite astonishing what's happened in the last year. So I think that would be my comments on that, just that, so again, that need for domestic self-sufficiency, looking back over what's gone on in this last year and seeing where we can go from here.
Okay, maybe we can move to the next question.
Yeah, and just before we do that, Alec, I wondered if anyone wants to ask a live question, we would throw that out as well as we queue up the next one. If there is anyone in particular that has a question for the group, and maybe as we queue that one up, I'll ask. A lot of the commentary to date and some of the questions that we've answered as we went along, really, you know, when we throw together all of John's presentation, Rebecca's good work, and Victoria's good work, there's a theme here of, you know, we like to analyze, you know, and see what we can do better, but what can we do to actually implement? Because I think that a lot of the questions revolve around that. I mean, John told us all the work that went into all the background work you and Victoria, Rebecca are doing now in the midst of the pandemic, and what John was involved with, and Alec with SARS. But where can we make a difference hitting the ground, I think, this time around, that we weren't able to previously. And I think that's what a lot of the commentary is saying. So maybe I'll throw that to the panel and sorry for the difficult one, and then while we pull up the next.
That's a great approach, Kimberly. Maybe we could have each panel member no more than 1 minute. What's your highest level, most impactful, useful response to that? Maybe start with Victoria and then go right through Rebecca and John.
Oh, no time to think. You know, Alec, I'm going to borrow from some of the conversations we've been having this week in our workshop. And I think, you know, I wasn't around for SARS the first time. You know, I think we learned a lot, but we didn't follow through. I think really the preparedness piece and getting workplaces to have better preparedness plans, and that could help them in future pandemics, but also other emergency situations. But really embedding this preparedness piece into the health and safety planning is perhaps one of the best suggestions I've heard so far.
Rebecca? Looks like you might be muted.
Sorry about that. I was muted.
There you go.
I think that supporting Canadian manufacturers. I don't think that means that you have to give contracts and just redesign procurement just to support people because they're Canadian, but to support them because they're maybe making the best stuff with the lowest environmental footprint. So I think having domestic manufacturers is so important, and it has implications beyond just pandemic response, but that relying on cheap imports from China doesn't do our economy and our environment any good. And so really focusing on supporting Canadian manufacturers and then all the wraparound that they need to be able to, again, do all the standards, develop and make things here properly, I think is a big one. So, just thinking more about circular economies, how to also spillover effects beyond just pandemic times. And then we heard from a lot of people in the space. Again, I've had the luck of speaking to a lot of stakeholders in this space who just said, we didn't learn lessons from SARS. Public health funding has been eroded, and that's reflected not only in that stockpile, which is a very physical manifestation of that erosion, but just in the expertise and the voice, and overall, so just strengthening the public health space, which is our insurance policy that we don't see in the good times, but boy, do we need it in the bad times.
Maybe John, if you could comment, and I'll just mention, John said something in his presentation that really, I just had a really emotional response to it, which is that he and some others who've been on this webinar actually reached out to the public health folks in good times to try to have a conversation that would help in tough times. So I'm really interested, John, in your perspective. How can we avoid the kind of conflictual, difficult year we've had in future and have a more collaborative approach? Any comments on that? Because I know you tried.
Yeah, we tried. And at that time, there was responsiveness to it. In fact, I think the government had produced a document, and Nancy, who's on the call or on the session here, could speak to it, Nancy Johnson. It was building a more resilient healthcare system. And I think it's still available online. And early in the pandemic, I heard an economist do an evaluation of the logic of efficiency versus the logic of resilience. If you run your healthcare system at 100%, you're extremely efficient, but you're terribly unresilient, because if something happens, you're overwhelmed. And so building resiliency into the healthcare system, into the pandemic response, into workplaces, so that I think Victoria also hinted at this, that this is not just, this is a teachable moment. There are so many things, ventilation in the workplace and things like that, that we're now focusing on, that we can learn to do better after the pandemic. And, I've been here too long and seen too many failures to hope that, we'll learn from this. But, what does it take really for people to learn? If it's not this pandemic, then I'm not sure what it will take.
Thanks very much, John. Kimberly, that was a terrific question to get to pull a lot of things together.
Yeah, and so we'll pull up another, but as we do, Jennifer, I think you have one for Victoria. I guess the other one in general, just summarizing a lot of the commentary, is we keep messaging that we need an interdisciplinary approach, and how fascinating that is. And look, we've provided it to you during this whole series. We've tried to gather expertise from various regions, and Rebecca, being a health economist, and is an exemplary example. Yet I think, and we've noticed this with some other projects, how do we bring together interdisciplinary expertise and listen at the same time? Because I think we get so focused, so a lot of the commentary is around occupational health and safety not being heard, or the dynamics between airborne and aerosolized, right? These small words that get in the way of, so they create barriers rather than the ability to work together as interdisciplinary teams. So, it's also a tough one, but we call for interdisciplinary, but then it doesn't work if we aren't hearing one another and we really stay to our narrow focus. So is it an occupational health and safety issue? Is it a public health issue? Is it a supply issue? Is it a design issue? Is, there was some unfortunate reality in the commentary that I have to mention, with regard to Reg 833 not being applied right now. And we were informed that literally because, we're of words. So that this biological chemical is not being used, processed, or applied in the workplace. So it's not an agent coming in that all of a sudden our health and safety precautions don't apply. So that doesn't make sense, but those words are in the way. I just wondered if people had comment about how to hear without, if we want to use an interdisciplinary team, how do we hear everyone and find bridges, not barriers?
Let me, maybe we could
Neither
go
is
through
carbon monoxide something that's manufactured or processed or used.
So let's
Yep.
do it this way. We're coming into a time crunch. So let's try to be under a minute each. And I'll just add sort of another little turn to this. We're here talking interdisciplinary, and of course it's all these disciplines, all these technical experts. Somehow or other we have to encounter the real world, the front line of workers and employers. So that's a really big part of the team. The team really should include listening to the workers and employers. And I think, John, maybe start on Kimberly's question, you maybe with my expansion a little bit, because you've been so involved with that. And then let's under a minute from each person, and then maybe we'll have a chance for a live question. It'd be great to finish with one, and then we'll wrap up, I think.
When we had the innovation forum, we intentionally got experts from all over North America in infection control and in occupational health. And we also had practitioners, people who do the stuff in the field, and worker representatives. So we had everybody there. We had a session that came up with a lot of positive suggestions and good ideas. Where it fell apart was simply the bureaucracy. It was a fluke of the bureaucracy that the key people who were pushing this got transferred to different ministries and things like that, and the new people couldn't follow up. So it's amazing. No one was fighting it. No one was against it. It was cooperative. We had all the levels there, but the bureaucratic support fell through.
So Rebecca, and you've been dealing a lot with that interface, I think, in the work you've been doing.
Sure. And again, we've spoken to stakeholders in the manufacturing space who are in technical experts, people with deep expertise on really specific things. And we heard again and again, people wanted communication and better communication, better networking. And I think maybe I'm hopeful that, the fact that we can do so many more things virtually, and that this pandemic has pushed us to virtual models, has made it easier to collaborate, easier to have networks. But I would echo that as well. That's something else we've heard from stakeholders, is that they can make networks. Someone needs to own it. Someone needs to maintain it and nurture it. It hopefully will be easier with more of a shift to virtual, but it needs to have an ear to government and decision makers. And so to have that relationship is a really important piece to obviously being effective.
So Victoria, this is a really great discussion.
Yeah, for me, I think the regulatory piece is really challenging for workplaces because they're being pulled in the public health direction and they're being pulled in the occupational health direction. And I think, from where I'm standing, better integration of, and I can see Dorothy's comment in the chat, and that's a very apt comment. Occupational health is part of public health, but they're, in our province, regulated completely separately. And one of the primary public health messages is to stay home. And for many workers, that's simply not possible. And we need to have better communications about how they stay safe while continuing to work. And I don't think we've done a good job there.
So Kimberly, do you think we have one more question we could? I know we've got an offer for a live question. It would be really good to hear at least one live voice from the audience.
Sure, yes, go ahead. I think it was Dan. Please unmute. Don't be shy.
I'm unmuted. I'm going to see if I can bring in some video. There you go. I'm actually here.
Great.
So I'm a professor at a school of aviation, and my work environment is I'm sitting in a small airplane, literally shoulder to shoulder with another pilot, talking loudly over engine noise for hours and hours on end. And I guess my question is, what resources, and related to what you're talking about, what resources can I pull or can I access to help analyze what the actual risks are from an airflow or air exchange standpoint, PPE, what are the options for improving safety?
So let's maybe start with Rebecca, because this is a typical question of a niche. It could be a dentist's office. There's so many different workplace scenarios. And on the other hand, there's expertise that can be applied. So maybe start with Rebecca, and then if either, probably John might have some comments too.
Sure. And I guess I should say this is my personal feeling. Because I before that had these messages saying that N95s are just for healthcare workers who treat COVID patients. I think you should be wearing an N95 or better, or just the PPE is so important. And then that solution around the ventilation, I don't know. There's also interest in things like UV disinfectant, investing in things like self-cleaning surfaces that have like nanotechnology or copper-infused technology, and how diffuse those might come in public spaces and workplaces, and how clean we want to make workplaces, both the air and the surface, I think is very interesting for the future. So on a practical level, I think wear the best possible mask you can. And then hopefully down the line, we'll have also some more better tech for keeping workplaces clean.
Okay, John, maybe yours probably going to be the last comment, and then I think we'll wrap up, because there's a debate coming at 2 o'clock, as you might have just seen in the chat. Okay,
well, the one thing about airplanes we've seen is that they can, if they're operated right, have a very high air exchange rate. So the number of air changes per hour can be adjusted to quite a high rate. As Rebecca said, a disposable N99, which allows you to actually talk and be heard. Elastomerics make that a little more difficult. But yeah, those would be the two things. If you look at our website about, we have a spectrum, it includes distancing, which probably isn't possible there, but cleaning, et cetera, et cetera. Also screening yourself for symptoms and things like that. So there's a spectrum of things, but they can all be optimized.
So on that note, a problem-solving note, front line, which is a great place to stop. We're going to wrap up. And I think I'm just going to suggest in public to Kimberly, what we're seeing here is there's a rich discussion of what a comprehensive preparedness for the next one could involve, and lots more to think about, lots more to discuss. And I want to thank all three of our presenters. You've done a fantastic job of both your own topics and weaving together with others. And Kimberly, Tony Lee, and others from, and Jennifer from OCal for making this happen still another time. And in behind the scenes, there's often some last minute elements to it. So thank everybody for participating. The chat's been very rich. There's so many ideas from so many people. And now we can go off to a debate.
Thank you, Alec, and Victoria, and Rebecca, and John, so very much, and all the participants for coming.
Okay, thanks everybody.
Stay well.
Have a good weekend.
Bye.